Hello and welcome to another Piper Pod. Today we're going to continue the pharmacological theme and we're going to have a look at something different, especially from a military point of view. There was a time that diabetes didn't even venture into the military side of the house. We may have had a couple of acute cases of hyperglycemia and hypoglycemia, but that was it. Recent times, diabetics type 2 are becoming more common in the military, and there's a lot of misconceptions associated with diabetes. And also, if you work in the greater population, you would definitely know that diabetes is a massive condition that affects a lot of people, and there's a lot of confusion about pharmacology and how to provide the best treatment for them. So today we're going to look at what diabetes is in the general overview, because we're going to be focusing on the pharmacology, and we're going to look at where we fit in the whole education piece of diabetic-based medication and management. So starting off, I think obviously we need to look at how the body maintains its homeostasis of glucose. Now, a few of you may be thinking that this is very, very easy, common, we look at this all the time. But just to draw on a couple of things that will help tie in with your pharmacology knowledge later on, you need to remember that when your blood glucose reduces, this can either be through not eating or exercise or some other form of pathological state, your body will sense that that happens. And when that happens, you'll have an increase of a hormone called glucagon. Okay, glucagon will be released by the pancreas, and that will cause the liver to go through glucolysis. So it will actually cause glucogen to be broken down into glucose, and that will increase your blood sugar levels. Other things that increase your blood sugar levels is obviously your eating. Now, when you have an increase in blood sugar levels, then obviously your pancreas releases insulin, and the insulin is involved in the storage of glucose. But what is often overlooked and not really talked about much, but is very important when you're dealing with pharmacology, is the concept of your stomach. So your stomach releases these special enzymes called incretins. Okay, and the main two types of incretins is your glucose-dependent insulin-tropic peptide and your glycogen-like peptide. So when the stomach registers there's a lot of glucose in it before absorption happens, it will actually release these particular peptides, and they will themselves trigger the release of insulin. Okay, so if it wasn't for these peptides, then there wouldn't be any communication between the high sugar level and the release of insulin in order to store it within the body, or knowing that that's what insulin does. Okay, it increases the amount of storage of sugar within the fats and the muscle tissues and things like that. Okay, so that's all we're going to talk about with glucose homeostasis, because we talked about it before in other lessons. I just wanted to draw on the concept of incretins because they play a big role in hyperglycemic agents that we'll talk about. So the main conditions, we obviously have type 1 and type 2 diabetes. Now, a few people, like back in the past, they tried to call these particular conditions insulin-dependent and non-insulin dependent diabetes, but general consensus is most people prefer the type 1 and type 2 diabetes mellitus. Okay, so we'll stick with those terminologies because there are times in which the type 2s will actually require insulin, and it gets that a little bit confusing if we keep it that way. So the difference is if we look at type 1 diabetes, if we look at diabetes in general, you have to think about diabetes as a metabolic condition. Okay, so it's the effects on the metabolism of carbohydrates, proteins, fats. It's a dysfunction with that metabolism that causes an increase in blood glucose. Okay, whether it's an insufficiency of insulin or not enough insulin, it's a metabolic disorder that causes a rise or mismanagement of blood glucose levels. Now, type 1 is often associated with the inability to produce enough insulin. Okay, so either no insulin or enough insulin to meet demands, okay, in normal situations of glucose intake. Okay, so we have this need that the body will be filled with sugar, obviously have high blood glucose levels, but there's no way for those glucose molecules to get into the actual muscles or the liver because there's nothing there to put it into it. Obviously that's what insulin does. So this often ends up in the need for the body to use fats and proteins to break down, and that's where it's associated with diabetic ketoacidosis. Okay, so type 1 diabetes is the inability to store glucose due to a lack or an absolute deficiency of insulin. Now type 2 is more associated with your lifestyle factors, okay? Often obesity, it's in your line, smoking even can have a big role. But the thing is, quite often you have a sufficient amount of insulin that is initially produced. Okay, so enough insulin is initially produced, but then a few things can happen. Okay, you can either have too much glucose in the bloodstream, so you're actually eating too much glucose, so you do not have enough insulin in order to store that much. So even though you're storing it, you still have a high glucose level. Okay, you can also end up having what's known as an insulin resistance. Now this doesn't necessarily mean that the insulin itself isn't there or doesn't work. Okay, what it actually means is the receptor sites in the target cells actually become resistant or have a reduced ability to be sensitive towards glucose uptake. Okay, so diabetes type 2 can be a combination of the two, where it's an inefficient or lack of insulin that is produced to meet demand, and also the cells, receptor sites being unable to collect that glucose. Now, diabetes type 2 represents about 85% of all diabetic cases. Okay, so it's far more common than type 1 diabetes mellitus, and it often affects adults around the age of 45. Okay, now there is a strong genetic and inherent link with it, and also a very strong sedentary obesity-based lifestyle as well. Okay, so how we diagnose diabetes mellitus. Now, in clinical practice, we often go through the finger prick test, okay, and we know the normal levels of blood glucose is supposed to be anywhere between 4 and 6, 4 to 8, depending on which textbook you read. Okay, and we know that a level less than 4 mostly is associated with hypoglycemia, and anything over 8 is associated with hyperglycemia. So blood glucose testing is done regularly. Now, the main test to get a diagnosis for diabetes mellitus is your hemoglobin alpha 1 test, is what we're actually going to look at. Now, the way this works is it actually will give you an average of BSLs for a 10 to 12 week period. Now, when glucose is in the presence of blood, red blood cells, a percentage of the actual glucose molecules will bind to hemoglobin. Now, when they bind to hemoglobin, they'll actually stick to hemoglobin and stay there for the whole duration of the cell's life cycle, which is about 120 days, and that's how you get the 10 to 12 week average BGL. Now, the greater concentration of glucose is going to represent a greater probability of these glucose molecules binding to hemoglobin, and therefore you'll have a higher percentage. Okay, so not every hemoglobin gets a glucose molecule. It's got to do with concentration gradients and a little bit to do with how fast the blood's moving, but mostly got to do with how much glucose is in the blood. So a high blood glucose level will be represented by a higher hemoglobin alpha 1 test. Now, the percentages that we look at, so we get a small amount of blood, we take it out, and then we look at it in a laboratory and we find out how many milliequivalent litres there are, and it's represented as a percentage. So if you have less than 7%, that's considered normal. Now there are some gradient ranges, but if you're under 7, it's not poorly controlled, or it's not likely to be diabetes mellitus, but you're at the higher end of normal. You want to be less than 5 realistically, but if you're 8% or over, then it suggests that you need some form of tighter control or some form of intervention on your diabetes mellitus. Okay, so that's the main blood test that is used these days, along with obviously clinical presentations and things like that. Now, our perspective, obviously we're not the ones that are prescribing the medication, but we provide a lot of education to the people that have diabetes mellitus. So when someone has a recently diagnosed diabetes, we have to look at that individual and their lifestyle and provide certain education. So when we're going through the assessment aspect of the clinical decision making, we need to look at how much that individual knows about diabetes, okay? How much misconception they've picked up in the past and how we can tailor that. We do a general overview, holistic based management of their history. So we look at their particular medical history, what their diet's like, exercise pattern, a way to educate them on the importance of these two aspects when dealing with especially diabetes mellitus type 2. We also look at other medications there are. Now, there's certain medications that will interfere with insulin itself. So your MAOIs are a classic one, your salicylate and your non-steroidal anti-inflammatories are a big interaction because they actually increase the probability of insulin resistance if you're taking non-steroidal anti-inflammatories that most people don't associate with. When we're looking at the person themselves, we look at factors of obesity, so height and weight, BMI, and fat percentage, things like that. And then we also look at their circulation problem, so feet, legs for ulcers, that sort of thing. If they are going to be insulin dependent, then we see if there's enough mass or enough fat mass that they can actually rotate the insulin sites. Okay, so not all diabetics, especially type 1, is associated with obese people. So there are some cases that people will have very few adipose tissue sites that they can actually inject. Okay, so that's your holistic assessment. When you move on to planning, you need to educate them on the finger prick, okay, and what's known as an acceptable range. You need to educate them on certain types of complications like ulcers or lipotrophy, which is essentially when you stick insulin into a same site, you can have this area of adipose tissue either enlarge, so growing and getting gross, or it can actually atrophy as well. So you'll end up with a misdemeanor of cellular growth of adipose tissue, and it looks quite unsightly. It's not very dangerous, but it looks a little bit unsightly. In conjunction with our assessment side of the house, whereas we've figured out how much exercise and diet control our particular patients have, we need to come up with clever ways in order to give realistic goals for medication adherence and diet and exercise adherence for these particular people. As also, we need to figure out a way to educate them on the importance of monitoring their blood glucose levels and how to recognize states of hypo or hyperglycemia as well. Once we get all the information and everything available, now when we're dealing with the military, we can also get the policy of PULHEMS as well, because certain medications and certain states of diabetes mellitus will distinguish as somebody's MET class. Okay, and if they're not educated on that, then if they do not manage their diabetes mellitus effectively, then the need for further medications and further managements are more likely, which will lead to a lower med class and more likely to be discharged. So just keep that in mind if you're ever dealing with military personnel. But when we move into the education side of the house, we may have to teach them about diabetes mellitus. We may have to tell them about times and how glucose requirements change during stress, during illnesses, during trauma, that sort of thing. So just educate them on how the body uses glucose and what they can do in order to manage it. If they are going to take insulin, they need to be instructed on how to do that properly, and they need to be given full information on reasonable diet and exercise. You don't have to go too in depth in there, but just recommend areas that they can get good information on that. Dietitians, nutritionists, physical therapists, that sort of thing. In regards to seeing clinical features of hypo or hyperglycemia, just give them early telltale signs. Okay, so like feeling faint, feeling dizzy, nauseous for hypoglycemia, or increase in urination despite the fact of how much water is being drunk for hyperglycemia, in case they're in a state where they can't actually test their blood glucose level. Okay, once this is done, then you can move on to the evaluation stage. So if someone's had diabetes for a while, then test them on their ability to take their blood glucose level, check their bodies for ulcers and signs of lipodystrophy, and get them to educate you on diet, exercise, things like that. Okay, now the main point of this clinical decision-making process, it may seem like a whole wishy-washy things that's not really clinical, not really sciencey, but it's the main part of our role in this, okay, is to provide the education. Now, diabetes across the board is grossly mismanaged, not often by the clinicians, but it's often by the patient's ability or willingness to follow medication regime. Okay, and that often comes down to education and coming up with a plan that actually fits in with the patient's lifestyle. Okay, so that's what this clinical decision making process is all about. It's about assessing the individual, finding out ways that you can come up with an idea to fit in with their world, offering the suggestion, and then evaluating whether or not it worked. If it didn't work, going back, assessing why it didn't work, and trying to change it further. Okay, the goal is obviously patient adherence to medications, because that's going to increase the amount of management that the patient is actually going to get. Okay, starting with the actual medications now. So we're going to look at mostly hypoglycemic agents. Okay, we're not going to talk about glucagon in this one. We're just going to talk about the different hypoglycemic agents in the use for treating diabetes mellitus. So insulin is obviously the most popular one. Okay, it mimics our own body's insulin. Okay, now believe it or not, it's actually recombinant human insulin that is used mostly in Australia these days. Okay, it used to be bovine, but now we have recombinant human insulin that is grown in by splicing and injecting human genes into bacteria and yeast, in case you're interested. So with that, we have a lot more compliance and a lot less side effects associated with it. Okay, so what insulin does is it stops glucagon lysis, which is the process of breaking down glucagon stores into glucose. It also inhibits gluconeogenesis, which is the process of making glucose from fats and proteins. And it does one more thing, which is stimulates glucogenesis. Now I know it sounds a little bit similar, but glucogenesis is the formation of glucagon from glucose. Okay, so it stops glucagon breaking down, glucagon lysis. It stops fats and proteins being formed into glucose, which is gluconeogenesis. And it also stimulates glucogenesis, which is the production of glucagon for storage. So It is the absolute frontline treatment for diabetic type 1, but it also can be used in your type 2 diabetes mellitus. Okay, so if BGLs are not controlled by other medications, diet, exercise, things like that, then it can be given as a top-up, and it's also often given in signs of trauma, extreme illness, or before an operation as well, just to help keep a little bit more control over the blood sugar levels. Now, there are many different insulin products out there, but every one of them is an injection. Okay, so you're not going to get a true insulin-based tablet form, okay, because insulin is a protein. If it was a tablet, it would actually be broken down by your proteolytic enzymes within your stomach, and therefore it wouldn't work. Okay, so it's always going to be an injection, mostly subcut, but it can be administered IM or IV. And the differences on the market are often associated with how quickly the onset is and the duration of them. So we have a lot of things available to us in order to be used, like a rapid insulin that is used more emergency based, and then you have a long-lasting insulin or a baseline insulin that is given for an entire day. Okay, it's taken once a day, so you have a baseline management. Now, the tricky part is that often these insulin injections are tried, tested, monitored, and then a regime is given for a particular individual. Okay, so there's no absolute recipe in which we can give. There's no management. There's a few protocols out there for management of insulin infusions when dealing with emergency states, but a lot of the time these insulins are going to subcutaneous pumps that will just monitor, and it will actually give the injection as you're going along. So they're very technical, and realistically, if you're not used to working with them, you shouldn't touch them at all. Okay, you shouldn't give advice. You should take it to a person that is more used to them, and believe it or not, the patients themselves these days have far greater knowledge on their own pumps than we could ever have. Okay, so listen to the patient and trust in them. Now, when we're dealing with side effects, the main side effect of insulin is obviously hypoglycemia. You can actually cause hypoglycemia. It's considered a high-risk medication, so it's associated with double checks and very close monitoring, because if you get the doses wrong, it's very easy to kill someone using insulin itself. Now, the other side effects of insulin resistance or lipodystrophy, they can theoretically happen, but since we moved to recombinant human insulin, those side effects have become significantly less. Okay, so moving from insulin itself, we're going to move into other types of hypoglycemic medications, and these ones here are mostly associated with type 2 diabetes mellitus. Now, this is, just a reminder, this is where we either have insulin that doesn't quite work because the receptor sites have changed, too much glucose being absorbed in the body, or a combination of both, and including a not enough perfectly functioning insulin to meet demand. Okay, so the first drug that we are going to look at is your sulfonylureas. Okay, now these particular ones, they are not insulin themselves, but what they do is they actually stimulate the release of insulin from the pancreas. Okay, so these particular drug classes are also used in cardiac conditions, because what they do, the way they work, is it actually binds to the receptor site on the actual pancreas or the heart, and it actually delays depolarization of your potassium channels. So it blocks your potassium channels, meaning the area or the cell membrane maintains polarization. Now, this state of polarization will actually open your calcium channels. Okay, so your ionized calcium channels, which will cause more calcium to be infused into the actual cell, And calcium is, as I've mentioned in a few lessons before, is a main catalyst for secondary effects within the body. So it is the presence of calcium that actually causes the degranulation and the release of insulin. Okay, so by taking these particular medications, we actually increase the amount of insulin that is produced. Now, on top of that, it also increases adherence of insulin receptor sites at the target cells as well. And on top of that, it inhibits glucogenesis as well, which is pretty good. Now, the problem with them is it's often associated with weight gain. Okay, so that's a side effect that is obviously not desired by a lot. So whilst being quite an effective medication, because its main side effect is weight gain, it's not the initial or the first frontline drug of choice, believe it or not. So the main drug of choice in treatment of type 2 diabetes mellitus is actually your biguanides. Now, the only one in Australia that is used is metformin. Okay, now I know we've all heard of metformin because it is, as I mentioned, the absolute main drug that is given with type 2 diabetes mellitus. Now, the way metformin works is, well, it does a number of different things. Okay, so the first thing it does is it increases the metabolism of glucose in the intestine wall. Okay, so it actually forces anaerobic metabolism in the intestine wall. Now, as a side effect, unfortunately, this increases your lactic acid production. Okay, so this particular drug is associated with lactic acidosis, but it's quite a rare side effect. Now, in the liver, it decreases glucogenesis, okay, and glucogen lysis. So like your insulin, it does that. It actually reduces the production of glucose, and it slows down fatty acid oxidation. Now, what that means is your fatty acids, your triglycerides, when they oxidize, they actually break apart, and you're left with a glycerol molecule that can be used as glucose easily. So it reduces the amount of fatty acid oxidation, which in turn means that you don't get extra sugar in the body. Now, when it gets to its actions on the skeletal muscle, it activates uptake. So it actually increases the adherence of receptor sites for insulin to uptake glucose. Okay, it increases glucogenesis, okay, which means, again, like I mentioned, the production of glycogen. Now, all of these things working together, where we have a use of sugars, we have a reduction in the production of different types of sugars, and an increase in uptake in sugars, it overall effects is a reduction in blood glucose. Now, the dangerous, if you will, or the thing that we have to be careful about when dealing with metformin is you need to be aware that metformin is 100% excreted by the kidneys. Okay, so kidney function needs to be continually monitored with these particular ones. You need to have a look at your creatine clearance rates with patients taking metformin, and you need to be particularly careful when patients are going in for a CT or something like that, because the dye is obviously going to give an extra effort for the kidney to excrete, which is already working pretty hard to get rid of the metformin itself. Okay, a different type of medication, again, is your thiazolidine diols, which from now on will be called your TZDs, okay, because it is an amazingly hard drug to pronounce. Now, these particular drugs, they're similar to your metformin, okay, as they have multiple effects on the body. The difference is this particular one doesn't have any effect on the gastrointestinal system. Okay, so this one will increase the uptake of glucose in adipose tissue, okay, and whilst inhibiting gluconeogenesis. Okay, so that's the production of glucose from different substances. Okay, so it will stop that. It will also increase your insulin adherence at the site, so your insulin sensitivity at the receptor sites will be increased, which reduces the probability of insulin resistance. Okay, so it's a good secondary based drug to use. Now, it has been some cases where certain classes of these drugs are associated with cardiovascular risk. Some cases where these particular drugs can be hepatotoxic as well, so testing the liver is an important thing to do. Now, the main side effect associated with these as well is fluid retention, which is associated with weight gain, and you can also get a few headaches as well. Okay, as far as drugs that affect just the intestinal system, we have our DPP-4 inhibitors. Okay, so that is your dipeptidase 4 inhibitors. Okay, now what these particular ones do is it actually blocks an enzyme that is associated with the breakdown of your incretins. So remember at the start of the lesson I spoke about incretins, the main one being your glucose-dependent insulin-tropic peptide and your glycogen-like peptide. Well, these particular DPP enzymes actually break down those particular incretins. Okay, so if we have a drug in place that inhibits the particular enzyme, then we are going to have more incretins available, which means more ability to stimulate insulin secretion and suppress glucagon. Okay, so it's basically taking it right back to where it all begins and allowing the body to do what it's supposed to do. Okay, and the last class that we'll look at, this one here is not an oral one. Okay, it's the only example of a hyperglycemic agent for type 2 diabetes mellitus that is actually an injection. Okay, so it's a subcut injection, but it is not a substitute for insulin. Okay, so your anexotides are associated with being a pseudo incretins. Okay, so it actually becomes a incretins itself. Okay, so it mimics your glycogen-like peptide. Okay, now the main one out there is Bietes. So an injection of Bietes is actually, or Bietas is given, and what that does is it mimics those incretins. So it will bind to the receptor sites of the particular incretin and then stimulate the release of insulin. Okay, that's the first thing it does. Okay, the second thing it does, because it's mimicking those incretins, is it stops glucagon being released. Okay, so if you're not having glucagon being released, then glucagon is not going to be broken down. Glucagon isn't going to be broken down to produce glucose. You're going to have an increase of insulin. There are secondary effects associated with appetite suppressant, so that helps with weight gain or decreasing the amount of sugar that actually comes in. And another very cool thing that it does, it actually slows down your gastric emptying. Now, the reason that's important is if you're eating carbohydrates or sugar, now that need to be absorbed in the intestine. What happens there is by delaying the glucose getting into the small intestine, the body has the time to regulate the sugars that are already in the bloodstream, and then it will get more of a steady supply of glucose from the small intestine instead of already being high and then getting a massive influx of additional glucose into the bloodstream. Okay, so it actually controls demand in the small intestine as well. So it's a very, very effective drug. Now, a bit of a cool side note is this particular drug was actually synthesized from the saliva of a lizard, believe it or not. Okay, so the lizard had a pseudo-alamase product in their saliva, and from there these particular hyperglycemic agents were synthesized. Now, common side effects associated with these is basically just nausea, vomiting, and diarrhea. Okay, so they're a very effective drug, and they're often used in combination with other oral hypoglycemic medications, and it can be an injection as rapidly as twice a day, or as much as twice a day, or as little as weekly, okay, depending on the patient's particular need. Now, because that was a lot to go through, we'll just go through a little bit of a summary for the hypoglycemic agents that we have. So the big one is your insulin. Insulin's going to be the main one that is used, especially for all your type 1 diabetic mellitus. Now that affects just insulin secretion. Okay, so it takes over where the pancreas and the beta cells can't. Okay, so that's what insulin does. The other effects of medication, hypoglycemic medications, is usually a combination. Now, it has got to do with the stopping of glucose being produced. Okay, so it stops the production of glucose in the liver. Okay, so it stops your gluconeogenesis and it stops your glucolysis, which means your overall production of stored glucose is reduced. Okay, other things these drugs can do is stop glucose at the source, so either slow down absorption or actual stop absorption of glucose into the body. So if you have a reduction of the amount of glucose that's coming into the bloodstream, then you don't need to have the ability to store it. It just gets excreted. The other actions the drug has is by stimulating the release of insulin, either directly by ion channels or indirectly by mimicking your incretins. It still has the same effect of increasing insulin being released and decreasing glycogen being released. Okay. Certain drugs act specifically on the receptor sites themselves, so they actually make the receptor sites of glucose more adherent or less resistant, so when glucose comes along it can easily bind to it, allowing insulin to finalize its storage. So the overall end result is there's going to be less glucose in the blood, more insulin actually being produced, and more glucose that's being stored in the tissue as used by these hypoglycemic medications. The overall goal of all of these medications is to find a way that the medications can assist a particular patient's lifestyle to maintain a normal glucose level. Now, this is why we have endocrinologists and we have people, huge organizations that just monitor diabetes, because as I mentioned at the start, every diabetic's case and lifestyle and situation is going to be different, so it is often a combination and constant monitoring of the condition and the medication that is needed, which just means the importance of us being healthcare workers to increase our knowledge on diabetic medication and increase our ability to educate our patients on the best way to maintain medication adherence and diabetes mellitus management. Until next time, take care.